Hey there, everyone, and welcome back for part three of our EKG Basics series. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator for PHI over here in California. So let's get going on part three, which is actually looking at the 12 lead and looking at cardiac access. So we're going to talk about locations of injuries. We're going to look at cardiac access as far as our differential diagnosis goes, and then we are going to talk about STEMI. So the first thing that we have to understand is that the different parts of a 12 lead tell you or tell you what part of the heart you're looking at, and really more specifically, they can tell you kind of where the lesion is if you are having an MI. So if you're looking at an MI in V1 or V2, that's going to be your septum. If you're looking at your inferior leads, you're really looking at your right coronary artery. If you're looking at V3 and V4, you're looking at that big left anterior descending. If you're looking at your high lateral leads, you're going to be looking at the circumflex artery. So there's many different, or there's a ton of different information that you can gather by just seeing where the injury pattern is on a 12 lead. So let's look at this actual 12 lead and talk about what we're looking at. So the way that we kind of look at a 12 lead is we do almost this circle. And we kind of start around lead 2 and we end up kind of traveling in almost a circle around the 12 lead. So the thing to understand first is that there are different leads on a 12 lead that are contiguous leads. So contiguous leads means that, or a contiguous lead is a lead that looks at the same or a similar part as another lead. So we can think of contiguous leads as just leads that are partners, right? And so there are several partners on an EKG. The first is lead 2, 3, and AVF. Those are all looking at the bottom of your heart. So that's looking at your inferior wall or your right coronary artery. The second section that we look at is V1 and V2. That's going to be your septum or your septal wall, your atrioventricular septum, and your interventricular septum and your intraatrial septum is what V1 and V2 is looking at. And then you have V3 and V4. Those are your anterior wall leads. That is typically, if you have an MI there, we would refer to that as like the widowmaker, because that's a very bad place to have a lesion, is in your left anterior descending. And then V5 and V6, we're looking at the lateral wall, so we're looking at the distal portion of the circumflex artery there. Circling back around, we are looking at leads 1 and AVF. We're looking at the high lateral, so we're looking at that proximal circumflex artery. And then AVR is looking directly at the top of your heart. So we're really looking at your atria. The reason that AVR is negative is because if you think about where it's looking directly at the top of your heart, at the very tippy top of your atria. Electricity should always be traveling away from it, right? Because the SA node fires down to the AV node, and then the electricity goes from the AV node down through the ventricles. And if the AVR is looking directly at the top of your heart, all the electricity should be going away from it. So all of the electricity is negatively deflected. That'll be really important when we are talking about access here in just a few minutes. So when we're looking at a 12 lead, it is a 4-step process, and the absolute last thing we're going to look for is STEMI. We look for all the other things first before we start looking for STEMI, because 12 leads can be rich with information, and just straight looking for injury is not necessarily the best use of the tools that we have. So the first thing we're going to do is we're going to identify the rhythm. So is this a normal sinus rhythm, or some sort of sinus tachycardia or bradycardia, or is this a junctional rhythm, or is this an atrial arrhythmia like AFib or A-flutter? So we're going to identify the rhythm first. The second thing we're going to do is we're going to identify the cardiac axis. Is it normal? Is it left axis deviation? Or is there the presence of right axis deviation? The third is we're going to look for any disqualifying findings. So we need to look and see if it's a paced rhythm. Do they have left ventricular hypertrophy? Is this a left bundle branch block? And those three are going to preclude us from using normal normal criteria to locate STEMI, right? We know that with a left bundle branch block, we can't call a traditional STEMI based off of normal STEMI criteria because you should have ST elevation with a left bundle branch block. That's a normal finding in a left bundle branch block and with left ventricular hypertrophy. So we need to look for any disqualifying findings. And then 4, now we're going to be looking for any injury patterns. So is there ST elevation? Is there ST segment depression? Are there inverted T waves? Do we have pathologic Q waves? So on and so forth. So it's a 4-step method. Look at the rhythm, look at the axis, look for disqualifying findings, and then look for injury. So the first thing we're going to look at is cardiac axis because we've looked how to identify rhythms in the last few parts. So now we're going to be looking at the cardiac axis. So what is the axis? It is the direction that the electricity is traveling in the heart. And depending on what lead you're looking at, you should see electricity coming towards you, meaning that the QRS or the wave is going to be positive because if electricity is coming toward the lead, then it's going to be positive. If electricity is traveling away from the lead, then it is going to be negative. So it's really important in your differential because we can start to pick up things like blocks and things like a bloated right ventricle or left ventricle due to right ventricle maybe due to like a pulmonary embolus or something like that. So there's many things that we can pick up on a 12 lead, and oftentimes we can find them by looking at the cardiac axis. So if we look at the axis for the heart, we only look at leads 1 and AVF for axis, and you can see this little screen right here. So hopefully the video will pick up my mouse, and you see that the SA node fires down to the AV node right here, and then the AV node dumps that signal down through the bundle branches and up through the Purkinje fibers. So if we're looking at lead 1, we see that the electricity is generally going to be traveling toward lead 1 the entire time, and so lead 1 should essentially always be positive. If it's not positive, then we probably have some sort of bundle branch block because the electricity would be have to travel away from it. We also look at lead AVF and we see that the signal or the electrical signal should be traveling through these Purkinje fibers, and so lead AVF should also generally be positive. As just a general note, lead 2, looking directly at the very bottom of the heart, should be the tallest, most positive lead on your EKG. So looking at this right here, we see that lead 1 is indeed positive, meaning that the electricity was traveling toward lead 1 the whole time, so that is positive. And then we look at AVF and we see that AVF is also positive. So this person has a normal cardiac axis, a normal QRS axis because both lead 1 and lead AVF are positive. So what happens if they're not positive? So first, if they're both positive, we know that this is a normal axis. But what happens if lead 1 is negative and AVF is positive? So they're pointing toward each other. That is right axis deviation. And we think when we think of right axis deviation, we should be thinking of a lot of right heart problems like a right heart strain or right ventricular failure or a pulmonary embolus causing right ventricular hypertrophy. There are many things that can cause right axis deviation, and oftentimes it may be completely benign, but when we think of right axis deviation, we need to think of right heart problems. So remember the saying that right reaches. So if the lead 1 and lead AVF are reaching for each other, then it is right axis deviation. If lead 1 is positive and AVF is negative, so they are leaving each other, then it is left axis deviation. So remember that left leaves and right reaches. So left axis deviation, we think of left heart problems. So we think of things like a left bundle branch block or left ventricular hypertrophy or maybe an anterior fascicular block or something like that. So normal, they're both positive. If they're reaching for each other, it is right. If they are leaving each other, it is left. And if both of them are negative, then you probably have like VTAC or something like that, because extreme axis deviation shouldn't happen unless you have some sort of ventricular arrhythmia. You may see it with like an idioventricular, maybe even like a junctional arrhythmia, but you should never see it under normal circumstances. So when we think about left axis deviation, these are the three big ones that we kind of look at. We look at left ventricular hypertrophy, a left bundle branch block, and a left anterior vesicular block. The top two are the most important, because if you find those two, it means that this 12 lead cannot be used under traditional criteria to diagnose a STEMI in the field. So let's look first at LVH, or left ventricular hypertrophy. So what we need to do is we need to take the biggest negative in V1 or V2 and add it to the biggest positive in V5 and V6. If it is greater than 7 little boxes, or 35 millimeters, meaning 35 little boxes, then left ventricular hypertrophy is present. And we're going to practice that on a 12 lead here in just a few minutes, and it'll make a lot more sense. So the biggest negative in the septum plus the biggest positive in the lateral leads, if they're more than 7 big boxes, then LVH is present, and that patient could be very sick. If this left ventricular hypertrophy is a new onset LVH, then that patient could be pretty sick. But if this is a chronic issue, but they're currently having chest pain, we cannot call this a STEMI in the field if they're having ST elevation, because ST elevation is a normal finding with LVH. The next thing we look at is a left bundle branch block, and you guys have already gone over a left bundle during the previous part. So we know that if the QRS is wide, it's greater than 0.12 seconds, or 120 milliseconds, and it ends with an S wave, then left bundle branch block is present. A left anterior vesicular block, I'm not going to spend a whole lot of time with. Essentially, you have a QR in lead 1. You should never have a Q wave in lead 1. And then you have this RS in AVL. You have an RS in the inferior leads, and that is a left anterior vesicular block. Not important for you guys to be able to recognize that in the field, but a left ventricular hypertrophy and a left bundle branch block, absolutely we need to be able to recognize these, and we're going to look at this one first. So we know that we are going to first identify the rhythm. So the first thing that I do to identify a rhythm is I look for P waves, and I see that there are in fact P waves all over the place. So this is some sort of sinus rhythm. I'm going to now determine the rate of the heart rate, and there are many ways to determine the rate of a heart rate. I like to use what's called the 300 method. If you would like more information about that, feel free to email me and I'll give you good literature on the 300 method, or you can use the 6-second strip, or you can look at the number on the top of the 12 lead. But this EKG is about 90 beats per minute or so. So we have a normal sinus rhythm with some sort of block, right? So, so step one is to identify the rhythm. We see that we have some sort of sinus rhythm at a rate of 90, but the QRS is very wide. We are looking first at the cardiac axis, and we see that lead 1 is completely positive, and AVF is about half positive and half negative. But AVF should be completely positive. So if it's about half negative, then I will count that as a negative. So they are leaving each other because lead 1 is up and AVF is down, so they're leaving each other. So this is left axis deviation. When I think about left axis deviation, I need to look for my disqualifiers. So is this a left bundle branch block? Is this left ventricular hypertrophy? And we can first look for left ventricular hypertrophy. So we can remember that it's the biggest negative in the septum plus the biggest positive in V5 or V6, so the lateral leads. And if it's bigger than 7 big boxes, then it is LVH. So we measure the biggest negative in V2 because V2 is bigger than V1, and we can see that if we count the big boxes, we have at least 1, 2, 3, 4, 5, 6, about 6.5 big boxes at the minimum. And then we look over at V5 or V6, and we see that that is an additional 2 big boxes about from the isoelectric line. And so we're looking at about 8.5 to 9 big boxes, and that is way more than 7. So that is left ventricular hypertrophy. Meaning that we cannot call this a STEMI, even though we see that there's pretty good ST elevation in V2 and V3. This cannot be called a STEMI in the field because LVH is present. We also, looking at V1, see that V1 is pretty wide. The QRS complex is pretty wide, right at about 3 or more little boxes, and it ends in that S wave. So I would say that this is actually left ventricular hypertrophy and a left bundle branch block. So this patient, we would say, has a sinus rhythm at 90 with the presence of LVH and a left bundle branch block on the 12 lead. If you were going to try to diagnose a 12 or a STEMI from this, you would then have to implement Scarbosa criteria because you could not use normal criteria to diagnose this as a STEMI. All right, so this one right here, we don't see any obvious left ventricular hypertrophy. We don't see any obvious left bundle branch block because it's very narrow, but let's start at the very beginning and identify the rhythm. Are there P waves anywhere on this 12 lead? Yes, there are. They're very small in some leads, but you can definitely see P waves in other leads. You can count out what the heart rate is. We have about a heart rate of 75. So this is a sinus rhythm at 75. We do see that there is profound left axis deviation. So we have a big positive in lead 1 and a big negative in AVF. So that's big left axis deviation. We already stated that we don't see any disqualifiers. So there's no LVH and there's no left bundle branch block. So this is an example of a left anterior fascicular block because we see that little QR wave in lead 1, and then in the inferior leads we see this big RS wave in all of the inferior leads. And so this is a left anterior fascicular block, but like I said, it's not a big thing that you guys need to be able to detect in the field. You're going to treat your patient. All right, this one, we have a sinus rhythm at a rate of approximately about a rate of 60. So we have a sinus rhythm at a rate of 60. We see big left axis deviation. Looking at lead 1, we see that it's very positive. Looking at lead AVF, we see that it's very negative. So they're leaving each other. So this is a sinus rhythm at 60 with left axis deviation. And so now I'm going to look for some disqualifiers. And I see that V2 is hugely negatively deflected. That QRS complex in and of itself is greater than 7 big boxes, and V5 and V6 are super tall. So the negative in V2 plus the positive in V6 is way more than 7 big boxes. So this is a sinus rhythm at 60 with left axis deviation and left ventricular hypertrophy. Hopefully this one is getting more and more obvious for you guys. So we do see some P waves, especially over in like V4, V5, and V6. I'm starting to see P waves pretty good. And so this is a sinus rhythm at a rate of about 110 or so. We see that there's left axis deviation, so we're looking for disqualifiers. We see that V1 and V2 are pretty short, and V5 and V6 are also pretty short, so there's no left ventricular hypertrophy, but we're looking at that V1 and we see that the QRS complex is fairly wide, and we see that it ends with an S wave, so this is a left bundle branch block. So we cannot call a STEMI by traditional criteria. We would have to use Scarbosa criteria in order to diagnose a STEMI on this patient, which if you know Scarbosa criteria, you would see that this patient does not meet Scarbosa. This is a normal looking EKG for somebody with a left bundle branch block. So this is a sinus TAC at 110 with left bundle branch block. All right, so now let's switch gears and go to right axis deviation. I'm much more concerned, honestly, about right axis deviation than I am with left. Left axis deviation can oftentimes be pretty benign, but right axis deviation, while it can also be benign, especially in children, it typically is not seen very often in adults unless there's something going on. And we can see that these three things that are listed here are actually pretty concerning things. So we have right heart strain, we have a sodium channel blocker overdose like TCAs or propranolol, and then we have hyperkalemia. So the first thing that we're going to take is right heart strain. So the biggest thing we're looking for is flipped T waves and leads V1 through V4. This, if you walk away with anything in this entire lecture, walk away with this. Right heart strain, which is the number one sign of a pulmonary embolus, is the presence of flipped P waves and leads V1 through V4. So the anteroseptal leads of this patient being flipped on the T wave is a big warning sign for the PE. So that's because when you have a PE, you get this big bloated right ventricle. So as the ventricles start to repolarize, it kind of switches the axis of that T wave and turns it inverted. So you get these big downward deflected T waves where you should normally see a T wave be fairly positive, and we'll look at that in a few minutes. We will actually talk about diagnosing a pulmonary embolus on a 12 lead in its own part in this lecture series. So we're just going to keep this at identifying right heart strain, but just understand that identifying right heart strain and identifying PE is very, very similar. So the next thing we're going to look at is a sodium channel blocker overdose. Something that we definitely see less and less of nowadays. We don't see a bunch of TCA overdoses, but we may still see some propranolol overdoses, and we do very infrequently see those Gen 2 TCA overdoses as well. So what we're looking for is, we've all known that we're looking for that wide-ish complex tachycardia. So we're not looking for VTAC, but we're looking for that wide complex tachycardia. But the big thing we're looking for is we're looking for a big, tall R wave in AVR. And it is, if you look for it, it is a very, very obvious finding of a sodium channel blocker overdose is AVR being positive in some way, AVR having a big R wave, because that's really weird for AVR, right? AVR should basically be completely negative, and if it's not completely negative, the first thing that we think of is, did we put our leads on inappropriately? And the second thing is do we have some sort of ventricular arrhythmia, or do we have some sort of toxicity going on? And in this case, it would be a toxicity problem. So a wide complex tachycardia with a big R wave in AVR, that is going to be your sodium channel blocker overdose. And then hyperkalemia, most people have hyperkalemia pretty down pat. So as you progress with a hyper-K state, you'll initially see those big peaked T waves, those T waves that look like they come to a point like a triangle, and then you'll start to see the PR interval start to get really wide, and then eventually the P waves will just disappear as they become eaten up by the T wave of the previous cardiac cycle, and then eventually the QRS will become wider and wider and wider, and it will slow down and slow down and slow down until eventually they are in an idioventricular rhythm, and then they go into cardiac arrest. So peak T waves, if that's all we see, but we still see good P waves, then we're pretty early in the progression. But if we're seeing wide complex tachycardia with peaked T waves and no P waves, that person is very toxic and needs some calcium and insulin really quickly. All right, so let's look at this first rhythm right here. So we are looking for P waves, and I see that I don't see any P waves on this rhythm that are obvious to me at all. So when you're looking at this rhythm, it can be very difficult to identify at first, but we can say that there's no P waves, and it's fast. The heart rate is a little bit above 100. So this is some sort of wide complex tachycardia. We look at the axis and we see that lead 1 is negatively deflected. So if we're looking at lead 1, This is the QRS complex, and then this is the T wave. So we have a QRS T, and we really just have a QST. So this is negatively deflected, and then we see that AVF is positively deflected. So we have this QRS complex, and then a little T wave, and a QRS complex, and a little T wave. So they are reaching for each other. So this is right axis deviation. When you think of right axis deviation, the things you should be thinking about are right heart problems or toxicity problems. So we look at hopefully the T waves that are just poking out at you and shaped like this big tall triangular mountain. And we see that this is a hyperkalemic state. So this patient has peaked T waves with a wide complex tachycardia and no P waves. This person is very, very sick. And I see on my notes that that patient had a potassium of 7.8. All right, so what are we looking at on this patient right here? I see obvious P waves. The patient has a heart rate of about 95 or so. So this is a sinus rhythm at 95 beats per minute. We're looking at the axis, and lead 1 is down, lead AVF is up, so they are reaching for each other. So this is right axis deviation. When I think about right axis deviation, I think about right heart problems. So I'm starting to look for any disqualifiers. I don't see any disqualifiers. There's no left bundle branch block. There's no left ventricular hypertrophy. This is not a paced rhythm. So now before I look for any type of injury like STEMI, I'm going to start to look for some sort of right heart problem. So what I see immediately is I see all those upside down T waves in V1, 2, and 3, and you could make an argument for an inverted T wave with a U wave in lead V4 as well. So I see that big inverted upside down T wave, that upside down T wave, and that one as well. So we're looking at a right heart problem, right heart strain. Typically, this is going to be like right ventricular hypertrophy. Oftentimes, it's going to be acute if the T waves are flipped. I also see the presence of a large S wave in lead 1, a Q wave in lead 3, and a flipped T wave in lead 3. For those of you that have studied 12 leads in the past, you would probably recognize that that means that there's an S wave in lead 1, a Q wave in lead 3, and a weird T wave in lead 3. So this is S1, Q3, T3, which is also a sign of a pulmonary embolus. But we'll talk about that during the PE portion and why S1, Q3, T3 doesn't really matter at all. And we really just care about the flipped T waves in the anteroseptum. All right, so what do we have for this one? I don't see any P waves. This is a wide complex tachycardia. The heart rate is right around 120. So we have a wide complex tachycardia at a heart rate of 120. I see that lead 1 is very negatively deflected. The QRS, it's just a little tiny R wave and a big S wave, so negatively deflected. And the lead AVF is essentially just an R wave, so they are reaching toward each other, so this is right axis deviation. So when I think about right axis deviation, I'm looking for right heart strain, I'm looking for toxicity, I'm looking for hyperkalemia. I don't see any peaked T waves. Those T waves are pretty rounded off, and so I'm not thinking any type of hyperkalemia at this time. I don't see any flipped T waves in the anteroseptum or the inferior leads, and so I'm kind of starting to wonder what's causing this wide complex tachycardia, and then I look over at AVR, and I see that AVR has that big, huge R wave. It's got a little Q wave and then this big R wave going way up above the baseline, at least 3 little boxes above the baseline, and that is weird for AVR. It should not happen. And remembering 2 to 3 slides ago that we said that a sodium channel blocker overdose, meaning a TCA overdose or a propanolol or procanamide overdose, you're going to have a wide complex tachycardia with a large R wave in AVR. So this is the typical 12 lead that you would see with a TCA or sodium channel blocker overdose. that big R wave in AVR. All right, so what's next? So we come back to this patient. We see that we have P waves. Our heart rate is right around 110. We have we have what appears to be a fairly normal axis. Our lead 1 is positive. AVF is also positive, and if both are positive, then that means that we have a normal axis. I'm looking for disqualifiers. So far I have that this is a sinus tach at a rate of about 105 with normal axis. I'm looking for disqualifiers, and I see that V2 is pretty negatively deflected, so I'm going to count those boxes, 1, 2, 3, 4, 5, and then V5 and V6 are pretty short, so I don't quite meet the criteria for left ventricular hypertrophy. The QRSs are narrow, so this definitely is not going to be a paced rhythm or a left bundle branch block. So now I'm going to start to look for some type of injury pattern, and I see that those those T waves are incredibly peaked. Very obviously peaked, and so this is going to end up being a hyperkalemia. So this is going to be a sinus tach at a rate of 105 with a normal axis and pretty marked peaked T waves. So this is going to be another hyperkalemia patient. This is going to be our calcium administration, and if it's going to be an interfacility, we're probably going to be giving insulin as well, and dextrose. All right, what's next? So on this patient, we see that we have P waves, so this is a sinus rhythm. The heart rate is right about 100. So this is, we'll call it a sinus tach at a rate of 100. We see that the lead 1 is about half up and half down, but there really shouldn't be any negative deflection in lead 1, and AVF is generally positive. So I would call this kind of borderline right axis deviation. You could also call this just a rightward axis. It's not quite right axis deviation because lead 1 is not all like really negative, but it's definitely leaning to the right. So I'm looking at some right heart problems. I don't see any disqualifiers. This is not a paced rhythm. This is not left bundle, and this is not LVH. So now I'm looking for problems that this patient can have, and I see pretty immediately that V1, V2, V3, V4, V5, and potentially V6, as well as lead 3 and lead AVF and lead 2, have flipped T waves, and this 12 lead is showing massive right heart strain, and this 12 lead actually was from a 28-year-old female that had a submassive saddle pulmonary embolus that had to be pulled out. But when you think of a 28-year-old female who has point chest pain and a little shortness of breath, you don't typically think of a massive pulmonary embolus, but this 12 lead would definitely point you in that direction if you picked up on that right heart strain. This one right here, we see some little baby P waves in V2 in the V leads, like V1 through V3. I can see a little bit of P waves. So this is a sinus rhythm. It's tachycardic. It's wide, and hopefully you keyed right into the fact that the T waves are not real wide or not real peaked, but that R wave in AVR is very tall. So this is going to be another sodium channel blocker overdose. Last one right here, we have a sinus rhythm at a rate of about 75 or so, about a rate of 80, and we're looking at a rightward axis, but relatively normal. I'm not seeing any disqualifiers, but again, I'm seeing those flip T waves in V1 through V5, as well as flip T waves in the inferior leads, and you really need to pay attention to that. This what looks like a LifePak 12 lead printout, even picked it up. It says anteroseptal T wave abnormality may be due to myocardial ischemia, but I am here to tell you that it is most likely due to a right heart or pulmonary problem and we really, really need to be paying attention to this. All right, so take-home points on cardiac axis. Axis deviation can absolutely be benign. Just because somebody has left axis deviation or right axis deviation does not mean that they're actively dying. However, it is absolutely a tool that should be going into your toolbox to improve your differentials on a 12 lead. It is not it's not the map, it's the compass, right? It's a tool to help you get pointed in the correct direction, but it is not the actual map itself. And understand that while both left and right axis deviation can be concerning, especially if that left axis deviation is new onset. Right axis deviation for me is much more concerning just because you have that pulmonary problem or that pulmonary component, that right heart component that is very difficult to treat in the field because oftentimes those are going to be a surgical problem. So moving on to STEMI. So STEMI is a great tool to be able to recognize. It's definitely not the bee's knees when it comes to identifying injury in the patient. It only accounts for about 60-ish% of all MIs. So we're missing quite a few MIs because they don't show up as ST elevation. In order to identify STEMI, or in order to call something a STEMI, we have to have ST elevation in at least 2 contiguous leads, meaning 2 leads that are looking at the same or similar parts of the heart. And the ST elevation needs to be at least 1 millimeter, or 1 small box above the baseline. And a lot of literature is actually looking for 2 millimeters for several parts of the heart. So what determines the baseline? So the baseline is that isoelectric line. It's where the electricity travels back to its kind of flat portion between heartbeats. That is the baseline, or the isoelectric line. Where ST elevation or depression is measured is in the J point. So it is the 90-ish degree deflection from the QRS complex going out toward the baseline or out toward the T wave. That is the J point. So if we look at this 12 lead right here, we can see that the red lines right here is our baseline, and then we can see the J point circled in yellow. So we see the J point is right there. It is the deflection right there going out toward the T wave. Same thing with that one right there, and then here's a few more right here. Those are the J points. So whatever the deflection away from the QRS complex is, that is the J point. And if the J point is above the isoelectric line, that is ST elevation. If the J point is below the isoelectric line, like in V2 and V4 on this picture, and V3 and V1, then that is ST depression. So the J point above, ST elevation, J point below, ST depression. So if we're looking at this 12 lead right here, we see, if we're looking at this 12 lead right here, one thing to help you with 12 leads is that a 12 lead should generally be able to hold water. And what I mean by that is that the leads on the outsides, leads 1, 2, 3, and then AVF, V3, and then 4, 5, and 6. So all the leads on the outside should be generally positive. And all the leads on the inside, like AVR, V1, V2, and AVL, those should generally be negative. So it should kind of create this little cup in order to hold it. If you're looking for injury, if your EKG does not look like this, if it's not positive on the bottom and the outsides and not generally negative on the middle, then there's probably some sort of injury pattern going on because the electricity is not traveling through the heart like it should be. So we're going to be looking at this 12 lead right here. And the first thing that we're going to do, step 1, is identify the rhythm. I see P waves, so this is a sinus rhythm. I see that the heart rate is pretty slow, right around 60 beats per minute. So we have a borderline sinus bradycardia. I don't see any disqualifiers. I see that this is a normal axis So now we're going to start to look for injury patterns. I do see that the T wave in V2 is generally kind of peaked, but that's the only real lead that it's super peaked in, and so I'm not thinking that this is a hyperkalemia issue. So now I'm going to start to look for injury, and I see that there is definitely some ST elevation and some as well as some ST depression in certain leads. So what leads do we mainly see ST elevation in? I see ST elevation in lead 2. I see a little bit, maybe a millimeter in lead 3 as well. And then I see a little bit in AVF. And I also see elevation in some other places. And hopefully you guys can see it too. I also see elevation in V5 and V6. So what would we call this? This type of MI. So we have an inferior wall MI, but we also have involvement in the lateral wall. So this patient is having an inferolateral MI, and if we if we know our cardiac anatomy, then we would say that this is probably the patient who is having some sort of distal lesion to the circumflex artery, and this is a patient whose inferior wall is at least partially fed by the circumflex and not just solely fed by the RCA. Otherwise, we probably wouldn't be seeing ST elevation in the inferior wall. But this is an inferolateral STEMI and is probably caused by a lesion to the circumflex. So let's look at this one right here. So the first thing is we see that we have P waves. Those P waves are pretty far back there though, right? So this is probably a first degree block. So this patient has a sinus rhythm with a first degree block. The heart rate looks like it is about 75 right on the nose. So we have a sinus at 75 with a first degree block. I'm looking at my axis and I see that they are definitely leaving each other. So this is left axis deviation. Looking for any disqualifiers, and I see that my QRS is narrow, so this is not a left bundle branch block. And I see that my QRSs are not super tall, so this is not LVH, but I definitely see some ST elevation, some pretty substantial ST elevation all over my V leads, and maybe even a little bit in lead 1. So this is a very large anterior, an anteroseptal MI, or anteroseptal STEMI. But what about the rest of the heart, right? So when we do a 12 lead, we are only really looking at the inferior left ventricle, the anterior and lateral left ventricle, but we're not looking at the right ventricle, we're not looking at the backside of the heart, and so that's where looking for those reciprocal changes and doing an additional either right-sided or posterior 12 lead can come in handy a lot of the time. So if we're looking at this particular 12 lead here, we see that this is a sinus rhythm at it's actually irregular, but we see that this is a sinus rhythm at a rate of about 85 or so. We see that the axis is a leftward axis, but still probably normal. I don't see any disqualifiers. I don't see any left bundle branch block or any type of LVH or anything, but I do see a lot of injury, right? So I see a lot of ST elevation in lead 3. I see a little bit in lead, maybe a little bit, but not much in AVF. But I do see a lot of ST depression in my septum, a little bit in my anterior, but definitely in my high lateral leads. That V1 and AVL, those are very negatively deflected. And so if we think about us looking at the high lateral portion of our left ventricle, what's on the direct other side of that? We're looking at the posterior portion of the heart, or the posterior right portion of the heart. So if we take some of our leads, like let's say V4, V5, and V6, and we put them on the back of our patient, and we do like a posterior or a right-sided 12 leads. So we take V4, V5, and V6, and we place them on the right side of the chest in the exact same spots that we would put V4, 5, and 6 on the left side. And we now have this V4R, V5R, and V6R. Now we're taking a right-sided 12 lead, and that's what they did here. So they did a right-sided 12 lead with actually V3 through V6, and now we see this huge elevation in V3 through V6. So this patient is having a massive right-sided MI, so probably a proximal RCA occlusion, but we weren't really appreciating how much of an infarct that this patient is having by just doing a simple left-sided 12 lead. So it's really important that if you see that large depression in contiguous leads, that you maybe need to think about the fact that there is injury happening somewhere. We just can't see it with that traditional 12 lead, so we're going to need to move it around. With this patient right here, so we identify the rhythm. It is a sinus rhythm because we see P waves. We see that the heart rate is right around 60. So it's a borderline sinus tachycardia. We see that it is definitely a leftward axis because that little teeny tiny QRS and AVF is going down, so there's a left axis deviation. I don't see any disqualifying agents. I do see maybe a little ST elevation in AVF and maybe a little in lead 2. I see a little elevation in lead 1 and maybe some of my lateral leads as well. But the big ticket item is recognizing that you have a lot of ST depression in V1, V2, and V3, as well as a little bit of depression in V4. So you have this huge anteroseptal depression, and if you're thinking about what's on the opposite side of your anteroseptum, it would be your posterior septum, right? So on this patient, we're going to do a posterior 12 lead with V7, 8, and 9. We're going to replace, typically it's going to be V4, 5, and 6 with V7, 8, and 9 to do a posterior 12 lead, and that's what they did right there. They replaced V4, V5, and V6 with a V8 or V7, V8, and V9 to do that posterior 12 lead, and now we see that they're having a pretty massive posterior MI. Now, granted, you can say that, well, I've got a little bit of elevation in my high lateral, a little bit of elevation in my inferior leads, but maybe not in contiguous leads, just some random ST elevation with huge ST depression in my septum. I have a pretty high index of suspicion that this is going to be a posterior MI. However, why not take the extra 15 seconds to put 3 extra stickers on their back and redo another 12 lead? 12 lead takes 9 seconds, and we can very easily get a STEMI diagnosis and start that pathway for getting the cath lab cleared and everything. But we can't say that we have a high index of suspicion for STEMI and get the STEMI team going. We got to say the magic words to get that STEMI team going. So that's all I had for this part. This is the longest part of the EKG basics. We covered a bunch from cardiac access to basic 12-lead interpretation. If you guys have any questions about anything, feel free to reach out to me at akaiser@phiaeromedical.com, and we'll see you on the next one.